It is my pleasure we're staying within the BGU family, and it's my pleasure to introduce our final student speaker for the evening, Molcho Haimovich, another PhD student at Ben-Gurion. We'll be speaking about behavioral intervention for ameliorating sleep problems in children with autism.
Hi, I'm in. Okay, thank you, Judah. My name is Alona. I'm a PhD student in Ben-Gurion University, and my wonderful advisors are Professor Ilan Dinstein, Professor Liat Tikotsky, and Dr. Gal Meiri. I am a behavioral analyst who's been working with families of children with ASD for the past 20 years. Today, I would like to present preliminary findings from a sleep intervention study that I'm conducting at the National Autism Research Center of Israel. Sleep disorders are more common in children with ASD as compared to typically developing children. At least half of children with ASD have sleeping problems as opposed to about 15% of typically developing children. Sleep disturbances have a large impact on the quality of life for the children and their parents, not only because of the sleep loss, but also because of the behavioral problems that sleep deprivation causes during the day, including irritability, aggression, increased repetitive behaviors, attention problems, and hyperactivity. So, what do sleeping problems look like in children with ASD? Most have longer sleep onset latency, which means the duration of time that it takes the child to fall asleep from lights off to sleep onset. Frequent night awakings, shorter night sleep durations, and early morning awakings. Sleep intervention needs to target these specific problems. Sleep intervention for young children 1 to 7 years old with ASD behavioral treatment consists of two main components. The first is parents' education regarding sleep hygiene. The second is training of different behavioral techniques that reduce parent involvement in the sleep initiation. So you can see the first goal of the behavioral intervention is to educate the parents to improve sleep hygiene. Sleep hygiene refers to healthy sleep habits. It is a set of behaviors that may help improve the ability to fall asleep and remain in quality sleep through the nights. As you can see, there are examples for different types of practices: establishing nightly routine, creating good sleep environment, avoiding stimulating activity just before bedtime, limiting access to electronics media devices, and there are many other recommendations. The second goal is to minimize parental involvement in the child's sleep onset. In other words, parents need to stop helping their child fall asleep. Children need to learn to fall asleep on their own, and parents often interfere with this ability. Several techniques have been developed to help reduce child's dependency on parental involvement during bedtime. These techniques may be characterized by total extinction, where parents ignore all destructive behavior during bedtime. Gradual extinction, where parents...
אלונה, הדף שלך מסתיר את המצלמה, בבקשה.
Okay. Gradual extinction, where parents are allowed to re-enter the child's room at fixed interval during bedtime. Another technique called bedtime fading, where bedtime is gradually set to earlier times each night until the desired time sleep onset is achieved. Because of our special needs of ASD children and the comorbidity with anxiety that they experience, in my study, I used the technique called camping out, which means moving gradually away from the child's bed until he falls asleep on their own. The principle behind all these interventions is the same: decreased parental involvement during bedtime. And here you can see the stages of the intervention in the photo. As you see, the intervention is accompanied by photos that suit for children in all functional levels. So, the main goal of the intervention is to examine the efficacy of behavioral intervention plan design for children 1.5 until 5.5 years old with ASD and sleeping problem. We are performing this intervention either in person at Soroka Medical Center or via online video conferencing using Zoom meetings. Another goal of the research is to compare the efficacy of intervention across these two settings. Finally, adapting the right treatment to the characteristic of the child and his family can be a significant breakthrough in the field and will perfect the understanding of how the children and their families' individual differences will moderate the efficacy of the treatment. So the third goal is to examine the relationship between the child's and the parent's individual characteristics and the efficacy of the intervention. My lecture will focus on the first two goals because I don't have yet enough data for analyzing the third goal. Okay. The intervention includes 2 parental workshops, up to 5 families each group, on sleep hygiene and practical techniques and behavioral principles that should guide parents to deal with their child's behavior during the process. Also, there are 2 weekly phone calls during the intervention's 8-week period. So, until now, 10 children completed the interventions, 6 of them in the face-to-face group, and 4 of them in online group. The intervention started in November this year. The mean age of the participant children is 2.9 years old. Parents fill out several questionnaires and a sleep diary over 5 nights, 1 week before the intervention and again after 8 weeks. We also measured sleep with the Fitbit sensor, which we tapped on the child's upper arm. The Fitbit is a sleep tracker that measures activity and heart rate and also identifies segments of sleep. The Fitbit used in parallel with the sleep diary during 5 nights before and after the intervention. Okay, so initial findings. Here we can see initial findings from the parents' questionnaire called CSHQ, Children's Sleep Habit Questionnaire, that estimates sleep disturbances. The left figure shows improvement on the total disturbances score of all 10 children. As you can see, the score changed from 50 to 46, suggesting that the sleeping problem decreased following the intervention. An interesting finding is that the mode of delivery may have an impact on this improvement in the figure on the right. The orange line...
אלונה, את נוגעת עם הדפים במיקרופון. אז זה עושה רעש.
Okay, sorry. Okay, so I'm a little bit nervous, sorry. So the orange line represents the group who met face-to-face with me, and the blue line represents the online group who met through Zoom. So far, improvement on this measure was apparent only in the face-to-face group. Okay, and here we see the findings from FISH questionnaire, where parents report how well they apply aspects of sleep hygiene at home. We can see that sleep hygiene improved following the intervention. The score increased from 42 to 50, suggesting that parents applied the hygiene rules that they learn at the educational meetings. For example, parents reported that children watch less TV before bedtime and kept child room quieter and darker. Here, you can see findings from the Fitbit measurements of sleep duration in 6 children, 3 from each mode. This shows that sleep duration increased by an average of 25 minutes. So you can see these are encouraging initial results that suggest the intervention has positive effect, but we of course need to enlarge our sample and are therefore recruiting additional families. If you know of interested family with 1.5 until 5.5 children with ASD and sleep difficulties, please let me know. Thank you. Thank you for listening.
Thank you so much, Alona.